to healthcare, to the patient, call their physician and are able to get next thing. They're able to spend up to an hour or even more.
Through only about 400 ovulations in their reproductive lifespan. Fertility preservation is different because there are multiple ways that could be done.
So today for our expert series, we have reproductive endocrinologist, Dr. Yetunde Ibrahim. She is a wealth of knowledge, and she's going to answer a lot of the questions that some of our patients have regarding the topic of infertility. So thank you for coming on, Dr. Ibrahim. It's so nice to have you with us.
Yeah. Thank you for having me.
Yes. So Dr. Ibrahim was born and raised in Lagos, Nigeria in West Africa before relocating to the United States for university education. She graduated as class valedictorian at Lincoln University in Pennsylvania, and then went on to complete her medical degree at Duke University in North Carolina. After serving her residency in obstetrics and gynecology at Beth Israel Deaconess Medical Center with Harvard Medical School in Massachusetts, she then went on to complete fellowship training in reproductive endocrinology and infertility at the University of Utah School of Medicine. Dr. Ibrahim is passionate about the rapidly evolving field of reproductive endocrinology and infertility. She has special clinical interests in assisted reproductive technology, fertility preservation, and advanced hysteroscopy. Her philosophy of practice is patient-centric and enhancing the patient experience while they undergo their individualized journey towards parenthood. So Dr. Ibrahim joined the fertility center at the Utah Fertility Center, rather, after practicing at the University of Texas in San Antonio as faculty in their reproductive endocrinology division. So we are really, really excited to have your wealth of knowledge here with us today.
I am excited too. Thank you for that lovely introduction. I really appreciate it.
Thank you. What I really wanted to do for this talk today was to look at some topics that my patient population would be interested in hearing about. And I know that infertility is kind of one of those topics that you are really the perfect person to answer a lot of the reproductive endocrinology questions that our patients have. So I'm really, really excited to have you here. At the completion of our talk today, I really want you to tell patients how they can see you, because I know that a lot of patients are going to want to have that one-on-one session with you. And it's really great that they'll be able to have that opportunity.
Of course, it would be my pleasure. I'd love to expand more on the age-related decline in fertility when we get to that part, because I do realize it was one of the questions that you wanted to ask me. So when we get to that part, I do want to talk a little bit more about that, because I think one of the ways our gynecology colleagues can help us as reproductive endocrinologists is identifying the patients that really should come see us, even if they haven't really thought about their reproductive goals, in the sense that we know there's an age-related decline in fertility because women are born with the maximum number of eggs they're ever going to have, right? At birth, we have 1 to 2 million eggs in our ovaries. And actually, it's one of the classic medical student questions, is that when does a woman go through the most rapid decline in the number of eggs in her ovaries? And that's actually before birth, right? Because it's about 7 million at 12 to 16 weeks when we're still inside our mother's uterus. And then at birth, it's 1 to 2 million. And that number continues to go down, such that by the first time that a girl has a menstrual cycle, around the average age of 13, that number is down from 1 to 2 million to 400,000. So we know quantity is reducing. Every time we ovulate, we lose about 1,000 eggs. So it's something that's really important to really find those patients who will come in for a well-woman visit, right? And I haven't really thought about their reproductive plans, especially, women of color. These are not things that are really being discussed with them. And one thing I tell you that reproductive endocrinologists cannot fix is that age-related decline in fertility, right? There are very, very limited options when women get to 42, 43. So
Right.
catching them earlier on, between 35 and then is usually a really good area where we can actually truly counsel women about the options they have.
That's awesome. That's
Yeah.
awesome. So, Yetunde, what would you say to a 35-year-old woman who maybe didn't have access to your expertise and hadn't had that discussion with her physician previously, and is now at the point in her life where she wants to start either trying to conceive or thinking about her plans for reproduction? What would you recommend for that patient?
Great question. And, I think, 35-year-old woman who's never conceived before and now starting to think about it. I think the first question I would want to know at that point in time is she trying to get pregnant now, or is she trying to talk about options of preserving her fertility? Because those are two very different things and take them down different pathways. If this is a patient who is interested in getting pregnant now, then the next thing I need to do is just elicit a complete history from the patient. Are there risk factors I can identify that could put her at risk for infertility? For example, does she have regular menstrual periods? Does she get malignal symptoms with her regular menstrual cycles? Has she had any sexually transmitted infections in the past? Has she had major abdominal surgery? Does she have very painful periods? So eliciting a full history at that point in time will be incredibly important to get to identify risk factors that that patient might have. If she's trying to get pregnant at that point in time, then we go through the routine fertility evaluation for a female. That is, we do ovarian reserve testing, right? We do a dye test of the fallopian tube just to make sure that the tubes are not blocked. And then we do a pelvic ultrasound, right, to make sure there's no fibroids that need to be taken care of or polyps that need to be taken care of. And at that point, I can counsel the patients about the options for getting pregnant at that point in time, which could be a number of things. It could be donor sperm, intrauterine insemination. It could be InvaCell, right? Use of donor sperm with InvaCell, or it could be donor sperm in vitro fertilization. Those are the options available at that point in time. And for a 35-year-old with normal ovarian reserve, normal fallopian tubes, normal uterus, it is completely reasonable to start with a donor sperm insemination and to potentially walk our way up if that were not to be successful. The second pathway would be if she wanted fertility preservation, right? Because then she could freeze her eggs at that point in time, or we could actually retrieve the eggs from her and fertilize those eggs with donor sperm and then freeze embryos. Those are the options that are available at that point in time for a woman who's 35 years old who is interested in fertility preservation. And we do some routine testing as well, too, including a baseline ultrasound and ovarian reserve testing before we actually go down the path of fertility preservation. So that's the way that conversation is had whenever I have a patient who presents at that age interested in talking about reproductive goals.
Awesome.
Yeah.
So Dr. Ibrahim, if you could just kind of tell us, so a lot of our patients have a hard time getting in to see the reproductive endocrinologist. There's often a long wait to get in for those specialist consultations. What can she do with her physician? What can be done with a general gynecologist or even a family medicine physician, if you will, prior to that visit with a specialist?
So, if the patient has decided at that point in time that they do want to proceed with a fertility preservation option, then, what they can do with their gynecologist is pretty much start with getting the basic testing. She can get the AMH done at that point in time. Now, I want to be very clear that I don't recommend testing for an AMH in a patient who hasn't decided that they want to do the fertility preservation. And it's very nuanced. And the reason why I say that is that, some patients come to us and say, oh, I had my AMH tested just because I wanted to know what my fertility status was. And it was a little bit low. And I just sort of freaked out that should I be doing something about it? Now, the reason I say that is because that AMH value doesn't predict a woman's chances of getting pregnant. It doesn't, because people that have even lower than average AMHs, a lot of them get pregnant without any issues as long as they are ovulating regularly. Now, what it does help us with, that is us as the fertility doctor, is to come up with the dosages of the medications that they will need for IVF, because it is a predictor of how well they respond to those medications that we use for the IVF treatment. So if the patient has already told you that, I've heard about this egg freezing thing, I certainly want to do it. I'm not seeing the reproductive endocrinologist for another, 6 weeks or 2 months or whatnot, then one thing that we can start with, that you can start with the patient is getting that AMH, the test of ovarian reserve. Certainly, I like to get infectious disease testing on those patients because we're going to be dealing with the gametes. And then I get a vitamin D level on patients, and I get a thyroid function test on the patients as well, just because it's important to have that information before we proceed with the stimulation. I also just recommend that the patients get started on prenatal vitamins at that point in time. If the vitamin D is low, then we give them vitamin D supplementation in preparation for the process. Those are the basic things that we could do. One other thing that would be helpful to know is a patient's blood type and screen.
Okay,
as
great.
well.
Those are definitely all things that we can do as general gynecologists, and even some of those things can be done by a family practice physician as far as lab testing. Now, I want to ask you, because I know that patients who are seeking fertility can sometimes, be looking for information in various places outside of their physician's offices. And I see sometimes ads about different vitamins and supplements that may help with fertility. You mentioned some of the things that you recommend. Are there any kind of over-the-counter supplements that really have proven to have evidence to help with fertility, either fertility preservation or with increasing a woman's fertility? What are your thoughts on some of those?
I lost you for a second there.
Okay.
I think it froze. So I think you mentioned what vitamins or
Yeah,
supplements.
we see a lot of advertisements for different supplements and vitamins that may help with fertility. I sometimes see ads that come up. Probably after this talk today, I may see an ad that pops up. And I was just wondering, for those patients because we know that our patients often seek information outside of their physician's offices, are there any supplements that have had evidence to prove that they're helpful with fertility?
So, there are many supplements that are out there. I always like to say that, I don't know of any supplement out there that has been demonstrated in a very well-designed study to improve live birth after fertility treatment.
Yeah.
Now, there are some supplements that have some studies that demonstrate some benefit in improving like egg quality or sperm quality. For example, coenzyme Q10 taken by men has been shown to help to improve some sperm parameters. But again, it hasn't been taken as far in a well-designed study to show that it improves live births. Coenzyme Q10, can also be beneficial for the woman as well too. Now, we do have some studies looking at vitamin D as well too, because vitamin D is very interesting in a sense that it actually acts like a steroid hormone. So we're seeing some evidence that if patients have either vitamin D insufficiency or vitamin D deficiency, that is repleting those vitamin D levels can be beneficial along with the routine fertility treatment in patients who are infertile. So that's why I do recommend checking those vitamin D levels. There are also some other supplements out there. Again, nothing ever shown to improve live birth, but potentially could have some benefits to the woman as she goes through her journey. So another one that I can think of is called acai berry. Prenatal vitamins are certainly very important as they go through this process. But again, no great studies or well-designed studies that show that they improve live birth. But they are not harmful. They're not harmful. So when patients ask me about them, unless I know of certain that I feel like, could actually pose a problem, I don't stop them from taking it, certainly at that point in time. Yeah.
Great, great, great.